So we've been talking about how to communicate effectively with our resident or our patient, and now we're going to talk more about communicating with our healthcare team. I cannot stress good communication in all aspects of nursing to make sure proper care is being done. But when we're looking at the principles of effective communication, remember that communication is an exchange of information. So we need to be brief and concise. We need to use familiar words to promote understanding. And we have to remember that nonverbal behavior we talked about. It's very important that the nonverbal clues that you give someone are appropriate. Your nonverbal communication sometimes is the biggest indicator, the biggest impact that you're going to have in your communication techniques. Make sure you have the person's full attention when you're talking to them, and make sure you give them your full attention when they're talking to you. Speak slowly and clearly, and be aware of your own personal values and biases. So nonverbal communication: make eye contact, convey interest, maintain your appropriate distances, and try to avoid negative behaviors. Now, one of the ways we communicate with the healthcare team is the medical record. It's a written or electronic account of a person's condition and the response to their treatment. It is a permanent record and it is a legal document. The information is confidential. You always have to remember that HIPAA violations we talked about in the beginning when we were talking about patients' rights and we were talking about confidentiality. It is organized into sections, so it will be organized into their admission paperwork that will have a list of what their diagnosis is, their allergies, who their main contact information is. It'll have a history about what's been going on with them medically and why they're here. It'll have doctor's orders of what orders, medications, diet, exercise, treatments that should be done, and then progress notes for the doctor, and then nurses' notes as well. So there's going to be progress reports going every time the doctor sees the person, and then the nurses are going to also be noting each shift what happens in their in the chart as well. There will be a section for lab results. There will be a section for respiratory therapy, for physical therapy, and any other specialists that happen to come in. So this chart's going to be organized in these different sections. And when I say it's a legal document, the people who are taking care of the resident have a right to be in that chart. So one of the things we talked about in an earlier class when we talked about confidentiality issues, you do not have the right to get into any chart that you want to look at in a facility. You should only be in the charts of the residents that you are taking care of, that you have a need to know what that information is. Now, as far as who else is going to use that record, respiratory therapy well, physical therapy well, dietary well, the physician well, social services well. If they are involved in that person's care, they may need access to that legal document. The resident has a right as well. So if you're taking care of a patient in the hospital or a resident in the nursing home, remember that this is their document as well, and they have the right to access it. So you have to follow your facility's policy about that. Some facilities will make them sign a consent to get it, and then they'll make a copy for the person. Some people will let them see it, but the nurse or the social service worker will stay there with them to explain things to them. So if a resident asks you for their chart, just don't go get it. You have to find out what your facility's policy is. Military time is always going to be used in the healthcare setting. It decreases a lot of issues with potential confusion. So your military time works off of a 24-hour clock, and the clock starts at 0001 and it ends at 2400. So 15 minutes after midnight is going to be 0015. If we're talking 11:30 at night, it's going to be 23:30. So our clock is going to be in, so for instance, here I would have 1 o'clock, and 1 o'clock in the afternoon, I would add 12 hours to it because there's 12 hours in a day, so it would be 1300. 2 o'clock in the morning, I would add 12 hours to that, it would be 1400, would be in the afternoon. 6 o'clock in the morning, 0600, 1800 would be 6 o'clock in the evening. Now, midnight ends the clock. So 12:1200 is 12 noon. 2400 is midnight. And then 5 minutes after midnight would be 0005. Now, when you're looking at military time, it's 4 digits. There is no semicolon in it. There's no AMPM in it. It's more accurate. There's less chance of confusion. And so I have a couple examples here. 11 p.m. would be 2300. 8:40 in the morning would be 0840. 12:30 in the morning would be 0030. And 1:45 in the afternoon would be 1345. No semicolons, no AM/PM. Now, the nursing process is something we're going to talk about again in a later class, but it's a method that nurses use to plan and deliver care. When a person comes into the facility, they're going to come in with their medical diagnosis, the diagnosis that the physician gave them. But then the nurse, the RN, is going to assess that person and come up with nursing diagnoses, nursing problems that the healthcare team can help meet. And so we use this acronym called ADPI, and the A stands for assessment, the D is for diagnosis, that's nursing diagnosis, not their medical diagnosis. P is for planning, I is for implementation, and E is for evaluation. So the assessment part involves collecting information. So our observations are done. We use our senses, what we see, what we hear, what we touch, what we smell. Those are all going to be things that we are going to be observing. And that is going to be part of our objective data. Objective data is the signs that we observe. Subjective data is the things that the patient or the resident is telling us that we can't see with our senses. So signs are objective data. Symptoms are subjective data, what the patient tells you. So some observations to report at once. So for instance, if we had a change in the person's ability to respond. So let's say when we came on this morning, they were awake and alert, they were talking to us, and now they're confused or they're really hard to arouse, they're very lethargic. That would be a change in condition that we would want to make sure we report to the nursing staff as soon as possible. A change in the person's mobility. So mobility is their ability to move, to walk, to get around. If they were moving really well this morning and now all of a sudden they can't move or one side's weak where it wasn't before, that is something we need to report. Complaints of sudden severe pain. Okay, that is something you would want to make sure that you reported to the nurse. Now, when I'm talking about if I noticed a change in the person's ability to respond, that would be an observation. So that would be objective data. A change in the person's mobility, that would be objective data. But them complaining of sudden severe pain, that would be subjective data. That would be something the resident would be telling me. A sore or reddened area on the person's skin. So one of the things we'll be learning when we learn how to give a bath to a resident is we're always going to observe the skin for redness, sores, rashes, pressure areas, anything that doesn't look right on the skin. We need to make sure we report it at once. Sudden vision changes. Now, vision changes, this could be something that could be objective or subjective. It could be subjective, the patient telling us that they're having blurred or double vision, but it could also be objective if we used an eye chart or how many fingers, we held up 2 fingers, how many fingers can you see, that type of thing. Difficulty breathing the same way. It can be subjective or it can be objective. The patient may tell us they're having difficulty breathing, or we may notice that they're breathing fast, that they're making unusual sounds when they breathe, that they look like they're gasping for air. Abnormal respirations. Difficulty swallowing. Difficulty swallowing, the medical term for that is dysphagia. And it is DYS in front of a word is difficult. Difficulty breathing was dyspnea, and difficulty swallowing is dysphagia. That might be something they're telling us, or it might be something we're observing. Vomiting would be objective. Bleeding would be objective, and abnormal vital signs would be objective. But these types of things, when you see something going wrong with the resident, something's different than how it was before. They're not behaving the way they did before. We always need to make sure we get it reported as soon as possible to the nurse. So the nurse does the assessment, and then they're going to develop a nursing diagnosis. It's problems that can be treated with nursing measures. This is not the same as the medical diagnosis that the doctor did. The RNs can diagnose the problems, not the CNA. So the North American Nursing Diagnosis Association, known as NANDA, they have recognized certain nursing diagnoses as being approved. And your book talks about them. Your book has a couple pages of really common ones, and we'll go through those later when we look at planning of care of residents in a little bit more detail. But after the nurse does the assessment and comes up with the nursing problems, the nurse is going to develop a plan of care. They're going to make a plan on how to solve the problems. They want to set priorities and goals. They develop a plan of care for that resident. So in a hospital, we develop a plan of care. In a nursing home, we develop a plan of care. In home health, we develop a plan of care. It's nursing interventions, nursing actions that we can take to help that person reach their goals, to get better. The nursing care plan is a written guide about the person's care. It acts as a communication tool to the rest of the team, but that plan has to be realistic, achievable, measurable, and specific. And then there's care conferences where we share ideas of that with that person to help them improve on their plan or on their care. So implementation is where the CNAs are really get involved with this. So the RN is the one who does the assessment and develops that plan of care. But now the CNA is going to help with the implementation. Now it's not just going to be CNAs implementing the care. The LVNs will, the RNs will, respiratory will help, dietary can help, but CNAs will also be really involved in this. And the implementation are the steps that have to be performed to carry out that plan. So if we're helping with doing implementation of a plan of care, we want to report back to the nurse afterwards to let them know it was done and how the person did with it. And usually CNAs have assignment sheets that will tell you what you need to do for your resident. And then there's evaluation. We need to measure the goals. Is our plan working, or does it need to be changed? Some goals will be met. Some goals, that patient's going to get better and that goal is going to be met. And so then we can take it off of their plan of care. But maybe they have another problem now, and so we need to add that one to it. But the nursing process never ends. It's an ongoing process the entire time a person's at the facility, whether it's a hospital or a nursing home. We are looking at assessment, nursing diagnosis, developing a plan of care, implementing that plan of care, and then reevaluating it and determining what's working and what's not. And if the person doesn't have any problems, if the nurse does an assessment and there are no nursing problems, then why is that person even there? Because truthfully, if a person doesn't have any problems, they probably don't need to be at the facility. So this would be an example. So my nursing diagnosis or my nursing problem is an alteration in nutrition. And it says less than body requirements due to nausea. So our patient's nauseated, that means they're throwing up, and they're not able to eat well. So they have an alteration in nutrition. They're not eating as much as they need because of the nausea. That is my nursing problem, my nursing diagnosis. So my medical diagnosis was cancer. That's the medical diagnosis. I'm looking at what nursing problems does that person have because of it. So the nursing goal, the patient's going to be able to. So maybe my goal might be is that they can take in 75% of their meals within the next couple days. Or maybe my goal might be that by the end of the week, by the end of 2 weeks, they can gain weight. So I could word the goal either way, but my goal has to be measurable. This is measurable. I can weigh them. I could weigh them in 2 weeks to see if I accomplished my goal, or I can determine that they're actually eating 75% of their meals if they are or if they aren't. So this is a measurable goal, and you always want to date your goals. When do you think they can be accomplished by? When do you think that this is going to happen by? So what am I going to need to do? What nursing interventions, what plan of care do we need to do to implement to have this happen? So we can assess that the patient's foods, their food likes and dislikes. We can request a dietary consult. We can provide small, frequent meals. Or nursing may give an antiemetic, which is an anti-nausea pill, prior to eating. Now that is not all of these are going to be done by the CNA, but this is where we are going to be helping with. Here might be another problem. So my medical diagnosis is cancer. My nursing problem, it says constipation due to dehydration and decreased food intake. So my goal would be that the person can have a regular foreign bowel movement within the next couple days, and then every 3 days after that. So my nursing intervention might be to encourage fluids every 1 to 2 hours while awake, offer high fiber foods, increase their activity. Because we'll be learning when we talk about nutrition, food or high fiber foods, activity, lots of fluids, those will help with constipation if our patient's having a problem with that. Now, the difference between reporting and recording. Reporting is an oral account. So if I go up to the nurse and I say, Mrs. Smith is nauseated now, she's sick to her stomach, I am reporting. I'm verbally telling her what the problem is. Recording is the written account. So if I document it in the nurse's notes, then I am recording it. So reporting it is an oral account. Recording is a written account. And we are going to report whenever there's a change in condition, when asked by the nurse, when going on break or end of our shift, we want to report off to someone else. We want to be prompt, thorough, and accurate. And we want to report what we did or observed for ourselves and report changes in condition. Now, as far as the written account, there are most facilities have gone over to electronic charting, and some places still have some old school handwritten charting as well. And this is something that we will be charting and care planning we will be doing at a later time in more detail. I just kind of wanted to give you an introduction into this because this is a way that we communicate with the healthcare team. So we always want to make sure we have the correct chart. Anytime we're going to document in a chart, we want to make sure we're documenting to the right person. If it's not an electronic version, we need to make sure we're writing legibly. Every entry is timed and dated, and we use military time, so there's no confusion. We want to initial or sign each entry, be brief but complete, use correct medical terms and abbreviations, and you have to find out what your facility allows as far as abbreviations go. Every facility has different variations of what they'll allow and what they won't allow. Use neutral language. We don't use biased terms like they're drunk or they have bizarre behavior. We have to be more specific than that. And we cannot erase or scribble or use whiteout. When we make a mistake in a chart, you draw a line through it. You put your error and your initials on it. You can't just cross it out so nobody can see it. So for example, a documentation, I've got the date and the time. I'm using military time. It says ambulated 100 yards in hallway, tolerated well. When you do make a documentation, it's your first initial, your last name, and then your title. So as student nursing assistants, you would be SNA, student nursing assistant. My 10 o'clock entry, I have bathed and dressed, rendary on buttocks noted, K. Smith, RN notified. I don't leave blank lines, so I'm going to draw a line here because I have leftover space, and then it's going to be first initial, last name, and again my title. If I am letting someone else know that there's a problem, I need to put the person's name that I'm notifying. I don't want to just say nurse notified, because then if something goes wrong, or the nurse says, oh, she never told me, and they're going to say, well, who did you tell? Well, if you don't have it written down, you're probably not going to remember. One thing you need to keep in mind is when things go to court, it may be years before something would ever go to court. So if you ever have to testify about what you wrote, what you did, you need to make sure you tell a clear enough picture that you will remember and that whoever you're telling the story to can figure it out. I have an entry 2 o'clock. C/O, that's complains of, pain to stomach, pain scale 6. So we will be talking about pain scales at a later date, but pain scale is 0 to 10. 0 being no pain, 10 being the worst pain you could possibly imagine. Where would you rank that pain? So you always, when you report that someone's having pain, you always want to find out where the pain is and what the pain scale level is. And if I'm telling someone else that I'm going to pass this off to someone else to take care of, I would document who it was. So I put Mary Jones, LVN, notified, my first initial, my last name, and my title. Now, on electronic charting, there are some things that we will do on flow sheets. So for instance, vital signs, they have a place for you to fill in temperature, pulse, respirations, blood pressure, oxygen saturation, PO oral, that's oral intake, voided urine, voided is urinating, nutrition, if they fed themselves, if you had to feed them, what type of activity they did. So they're kind of just these check boxes that you just fill in, which makes it kind of nice nowadays because that way you don't have to worry about your legibility of your writing or anything. It's fairly easy to follow. Some common charting mistakes: illegible handwriting, using generalizations, vital signs normal instead of the actual numbers, overuse of abbreviations or improper abbreviations, spelling errors, omissions. Never destroy a chart. You're not allowed to. It's a legal document. And poor charting implies poor care. And you may be the best nurse in the world, but if you give really sloppy, poor writing, they're going to think you might give sloppy, poor care. So your electronic health records, one thing I cannot stress enough, don't share your password. Don't ever share your sign-in information with someone else, because if they get into your chart, if they get into somebody's chart and it's using your password, it's going to record that you were in that chart. And let's say it was someone famous or someone that you have no right being in their chart, and now it's showing that you were in there, you can get into a lot of trouble. Do not share confidential emails. Always log off the computer when you're done. Make sure the screen cannot be seen by others while you're working on it, and don't use work computers for personal use. Some really common healthcare terms, and these are terms that we will be talking about a lot as we go through this class. The term activities of daily living, ADLs, activity of daily living, those are the things you probably take for granted. You get up in the morning, you go to the bathroom, you brush your teeth, you take a shower, you get dressed. There are things that you don't even think about anymore, but this is generally what this is generally what a nursing assistant does. We will primarily be doing activities of daily living for another person because they have disabilities now and they can no longer do that for themselves. Assistive devices, we'll be learning about how to help with assistive devices, but those are things to help, like a walker would be an assistive device, or something, some feeding utensils could be an assistive device. Atrophy means wasting away. It's a wasting away of muscles. Care plan, we just talked about care planning. It's something that the nursing staff does to help make sure that the patient's getting the best possible care to meet their nursing needs. Cognitive function. Cognitive function is your ability to think, to rationalize, your judgment. That would be your cognitive function. So when we start learning about dementia, we're going to find out that dementia is a loss of cognitive function. It's a loss of your ability to think or rationalize or have judgment or understand, or your memory, to the point where it's affecting your activity of daily living. Contractures are where you have an abnormal shortening of a muscle. It's a really common thing we see in hands. Sometimes you'll see the hands kind of crinkle down and then they can't even open up. If a person cannot move a body part, you need to be moving it for them. You absolutely have to be moving it for them. So if you have a person who has a weak side and they can't move one side of their body, we have to be moving it for them. We have to do good range of motion to keep that from happening. Dysphagia means difficulty swallowing, and dyspnea means difficulty breathing. Feces is another word for bowel movement. Fever means to have a temperature. Fowler's position is a sitting up position, usually around 60 degrees. Incontinence is unable to control your urine, or some people have urinary incontinence where they cannot control their bladder. Some have fecal incontinence, which means they cannot control their bowel movements. Some people will have both. Pressure ulcers. The prone position is laying on the stomach. Semifowlers is the head is barely up. It's usually up around 30 degrees, maybe 30 to 45 degrees. Signal light is another term for a call light. Supine is lying on the back. Vital signs, it's temperature, pulse, respirations, blood pressure, and pain level. Voiding is urinating or going pee. So we'll be learning about all these terms as we go through the class, and a lot more, but these are really common phrases we're going to be hearing in healthcare. As far as managing conflict goes, you're going to need to learn how to manage conflict. And one of the first things we do when we manage conflict is we need to define the problem. What is the actual problem? We want to collect as much information about the problem as possible, identify possible solutions, select the best solution, carry out that solution, and then evaluate the results. But you need to talk in a private setting. You need to listen to their side of the conflict, and hopefully the two of you can get together and agree on ways to solve it. You need to learn how to manage conflict between you and your coworkers, between you and a physician, between you and a family. when I have students come up to me and they say, well, so-and-so did this, I'll say, okay, so what do you think you need to do about it? What is the actual problem? What do you think some possible solutions are? How do you think you could approach this? Because you do not go to a nurse. You do not go to everyone else to try to solve your problems. You need to learn how to solve them yourself. Now, if you cannot solve it, if you have tried and you cannot do it, then your instructor will get involved with the situation. But generally, when you have conflict, you need to learn how to manage it yourself. And these are your steps. So we will stop there.